All right. Good afternoon. I'm Norman So, and I have a select audience here at the UW conference room with Dr. Weinstein and Dr. Swanson, and for those of you listening online. Dr. Hakimian asked me to give a relatively didactic talk on auras and seizure semiology, and so I will review that for you. Our purpose is to introduce you to the framework of terms used to describe auras and seizures and how they have changed, understand the importance of seizure propagation in a defined network, illustrate important semiological signs, and discuss the clinical utility of auras and signs in the localization and naturalization of seizures. I have no disclosures. Here are some of the greats that have contributed greatly to our field. Hewlings, Jackson, and Gowers from the turn of the last century in Britain. And of course, Penfield and Jasper, pioneers in epilepsy surgery at Montreal. Henri Gastaut was a preeminent French epileptologist and very active in the classification of seizures and epilepsy. Shimoni Massan worked at the NIH in Bethesda and did wonderful stuff. And Jean Banco, one of the pioneers of stereo electroencephalography, who was active in Paris. Now, many of you were brought up using this 1981 International Classification of Epileptic Seizures. And foremost in that classification is a dichotomy based on the initial onset of the seizure in the EEG, therefore separating focal or partial seizures from generalized seizures. And you all had to deal with this unusual use of English, simple versus complex partial seizures, to denote whether consciousness has been retained or lost in the seizure. Other terms are more familiar, like auras and automatisms. Thus, we are in the international classification from 1981 have these major categories for partial seizures, simple, partial, complex, partial, or partial evolving to generalized seizures, and a list of the classical seizure types in generalized epilepsy, absence and tonic-clonic, etc. While this is very helpful and very abbreviated, it loses a lot of detail. So a person with a simple partial seizure that is focal motor would be quite different from a simple partial that is sensory, like an aura. And there are many variations of complex partial seizures which are not described in this type of classification. In reaction, in the advent of video EEG monitoring for the study of epilepsy for surgical purposes, there are many different attempts to expand on the terminology and the terms used to describe seizures. And this was the Cleveland Clinic group that had tried to define a system of looking at seizures based on the signs and symptoms alone, independent of the EEG. And some of the terms introduced have not, of course, been uniformly adopted elsewhere, but they illustrate an attempt to expand our ability to describe seizures. In reaction, the International League Against Epilepsy in 2001, under Engel, proposed a refinement to describe the schema for seizures in each person, starting with ictophenomenology and then going through the other axes. A subtask force of the International League was responsible for the descriptive terminology, the task force on classification and terminology. And here they separated motor from non-motor symptoms and signs, and under motor separated elementary from more complex movements lumped under automatisms, and they ranged from simple tonic movements, clonic movements, etc. And for automatisms, many different types, which I'm not going to completely list out for you, but I can challenge how many of you know the word diachristic, what it means. In the explanation to this article. Diachristic means seizures with crying. For the non-motor symptoms, we have the sensory seizures, namely auras. A new term, dyscognitive, was introduced. That means an alteration in awareness. And in a way, this was a proposal to replace the term complex partial seizures. So a focal dyscognitive seizure can be used for a complex partial seizure. Well, the International League does not rest. In 2010, the latest iteration of the classification, there's a further revision of the terminology and concepts. As far as seizure types, we preserve the classical generalized seizure types. But for focal seizures, you are pleased to know, or displeased to know, they have no further classification and just advises us to use the descriptive terminology for ectosemiology from 2001. And a further category is called epileptic spasms. So here we are, we have a dilemma in the terminology for seizures. For populations, we like concise terms, categories, classifications to permit communication and analysis. But for the individual patient, we really want more detailed symptom signs and a picture of the entire seizure from its beginning. And the purpose of that is to permit an understanding of the epileptic network, which is very important for the localization of seizures if we are dealing with epilepsy surgery. So let's start with auras. The term was respectively breeze or soft air from Greek or Latin. In the 1981 classification, the aura is that portion of the seizure which occurs before consciousness is lost and for which memory is retained afterwards. Therefore, it is a simple partial sensory seizure, you can say. Now, at the start of a seizure, as the start of the seizure, the aura is experienced when the ictal discharge activates brain regions with access to consciousness and for which it can be recalled. And the reason why some patients have no auras could be multiple. It could be because the aura arose from functionally silent cortex. It could be because consciousness is interrupted early on, so the person has no access to retain, to describe what's going on. Or it could be because there is immediate amnesia, so that even if the person had an aura, they could not remember it. And we see that occasionally in the epilepsy monitoring unit. The patient would press the button to alert us that a seizure is about to happen, but they have a major convulsion, for instance, and afterwards have no idea what happened, let alone the aura. As far as auras are concerned, those which affect the primary senses are fairly easy for us to understand and categorize. And I don't have to expand on that. Those are the standard sort of major primary sensory auras affecting the different primary receptive areas of the brain. For other auras, certain categories are fairly well accepted in the epilepsy world. One category would be the abdominal epigastric aura. Another category is a cephalic aura. Then we have autonomic auras, a very rich category of experiential and psychic auras, and others which may or may not be classifiable.
Cephalic would be what?
Headache?
I will try to explain. The abdominal epigastric would be the typical butterflies in the stomach, rising chest sensation, various things in the midline that goes, for whatever reason, tends to rise up. Cephalic is any sensation referable to the head. And some people would use the word dizziness, lightheaded, something in the head. Some people would include headaches as in that category. Autonomic auras, let's say, with tachycardia, palpitations, chills, goosebumps, etc. Now, the richest category would be the so-called experiential or psychic auras, and again, there are many attempts to try and put them into a schema, and it's not always possible, but we can broadly say there are those which have an affective component, those which alter memory perception in some way, desmnesic, and the classic are the déjà and the jamais vu or entendu, as though you have experienced or never experienced in some manner. Then there are a big group of illusions where the perceptions are there but altered in some way. Those are the micropsia things, sounds changing, getting louder, softer, etc. Now, as separate from the auras affecting the primary sensory areas, in experiential auras, you have complex hallucinations where you have formed images, figures, scenes, memory of images and things that happened in the past. And then there are various other terms used, like the dreamy state, depersonalization, and autoscopy, which is the sensation of the mind being outside of the body, looking down onto the person. So I'm not going to try to illustrate how the aura activates different parts of the brain to produce seizure, the specific symptoms, but more specifically talk about the complexity of somatosensory auras. Those are the sensations of tingling, numbness, or even pain that a person may experience as part of the epileptic aura. Now, we all know, of course, the primary sensory area, S1, in the postcentral gyrus, and that gives rise to the classical Jacksonian march type aura, starting usually in the hand, face, or foot. Those are the areas with the largest representation, and then it marches fairly quickly up and down the extremity or body to another part. But there are multiple areas of the cortex that receive and sensation. And they each have their own homuncular type representation. S2, second sensory area, is situated in the what we call the parietal operculum, deep folded inside the sylvian fissure. Sensations there, if evoked, and that's based on electrical stimulation studies in patients investigated for epilepsy surgery, can be variable sensations, but usually involve large parts of the body, large segments, a whole limb, half a side of the body, etc. Another part of the brain that you can evoke sensations is embedded within the supplementary motor area in the medial frontal cortex. And this is another electrical stimulation study showing that electrical stimulation of this spot give rise to bilateral sensations in the body. So it's one of the, if you encounter people with bilateral sensations, that's one area to think about. Furthermore,
I don't get it though. How bilateral?
Well, the bilateral, it's probably through the connectivity, because these areas in the medial cortex have such strong commissurial connections that they often send things back and forth across the commissures. Now, in the insula, this is an area that for a long time we have not been able to study, but the French School of Electroencephalography uses depth electrodes placed stereotactically to sample these areas. And now it's possible to say that there are definite sensory areas in the insula, both for painful sensations more in the posterior insula, posterior superior corner of the insula, and more varied sensations in the rest of the insula. And in fact, in this very recent paper, some of which you might have looked at, in neurology, the Lyon group from France, I think, made it fairly clear that these areas, particularly the insular cortex and its neighboring second sensory area in the operculum, are the areas responsible for painful somatosensory auras in patients who report them. And they do not arise from the primary sensory cortex. So these are the primary sensory areas. And the idea then is a person has a specific sensation before a seizure. Let's say they hear a sound, then we say very likely it's arising near or from the auditory cortex. But we have to think beyond the primary cortical areas. There's a large territory of brain outside, and patients can still have aura sensations through projection of the ectodischarge. So let's take the case of visual phenomena as aura. Following the now well-described pathways for visual processing from the occipital cortex proper, V1, V2, V3 onwards, we have a dorsal stream that, also sometimes called the aware stream, that processes spatial, locational type information that projects all the way to the frontal cortex. And then the ventral or Watt stream that processes color, texture, pictorial detail, and allow us to recognize an object and name the object. So epileptic discharges arising from these other areas could potentially evoke a visual experience, which is different from that in the occipital lobe. So typically in the parietal lobe, extending forward, the visual phenomena, if experienced, would be an illusion, changes in movement, shape. The object is moving, the room is tilted. Otoscopy, the body is outside of the mind is outside of the body. And with regard to temporal stream, the discharge in the temporal cortex, we have more complex visual hallucinations of figures, objects, and scenes. Now, the same can be said for auditory auras. We have, with my fellow and some of my colleagues, described a couple of cases of auditory auras from the frontal operculum. And this is a patient with seizures starting with sounds changing, like receding. And interestingly, I don't know how it relates specifically to this, where the seizure started. Sometimes it would come on when he's playing or listening to rock music. But so initially, one would think, oh, the seizures are most likely arising from the auditory cortex. But in our presurgical evaluation, we saw that there was a significant area of hypometabolism in the inferior frontal gyrus, the frontal operculum here. His MRI was normal. Many other studies were completely misleading. This is our attempt to do the ectospec scan, which did not light up the spot at all. In fact, went to the opposite side. He was ultimately investigated with a series of stereotactic depth electrodes implanted orthogonally to sample from these different areas. And seizures either began exclusively from electrode Q here, or simultaneously electrode Q, electrode U, the mid-contact sample, the insular cortex. So in this case, we think that the seizures started in these areas from inferior frontal operculum, could sometimes travel through the insula to the auditory cortex. He did very well with a restricted, as you can see, small resection in the inferior frontal operculum and has been seizure-free.
This is on the right side?
Right side, yes. And thinking then is that ectodischarges can propagate through established pathways used that we all know are important in other functions of the brain. So in this case, the ectodischarge probably utilize pathways used in auditory and language processing. I know this is the left side and this is the right side, but there will be some rudimentary auditory similar pathways linking, I think, the frontal lobe and the superior temporal gyrus, the Heschel's gyrus for auditory processing. So other examples of auras as propagated phenomena or network phenomena, rather than just saying, oh, you have an auditory aura, your seizures must come from Heschel's gyrus in the temporal lobe, and seen in these other examples. In temporal lobe epilepsy, including those who have had temporal resections and are completely seizure-free, about 10% have somatosensory aura in different series. And of course, we know there's no real somatosensory representation in temporal lobe, so we believe it is from spread to the adjacent sensory areas, insula, second sensory area, maybe even the primary sensory area, but we think these are the more important. Now, in mesotemporal epilepsy, some patients have multiple auras. By that we mean many different auras at different times in different combinations, and that's very difficult to understand. One visit, they say, I have déjà vu and sickness. Another visit, they say, I have fear and déjà vu, and I see something. But there, I think what we are seeing is activation of a network linking the medial limbic structures like the amygdala and hippocampus to the neocortex in the temporal lobe, and evoking these different complex mental phenomena. Now, visual phenomena have actually been described not just in occipital epilepsies, but extending as far forward as frontal lobe epilepsies, of course in temporal, parietal, and occipital. And I think I tried to explain that in the previous slide, illustrating the visual processing pathways. And then for the auditory auras, we now have evidence it's not just from the temporal neocortex, but can be from neighboring structures, as illustrated. Now, this slide is just illustrative of clusters, so no need to look at numbers, and that's not the important thing. So these are series of auras in biggish series, from different lobes of the brain. Usually these are from surgical series. People have been operated on, seizure-free, so it's pretty clear what the localization of the seizures were. First comment to make is that it is very uncommon for a particular aura to be found in just one lobar region of the brain. They can be in multiple regions. The abdominal aura actually can be seen in just about every lobe of the brain. However, there are some exceptions. It would be highly unusual to find somatosensory auras in occipital epilepsy. For parietal lobe epilepsies, the somatosensory aura of different types would be the commonest. For temporal lobe, the commonest aura is abdominal aura of some sort, followed by psychic auras. And for frontal lobe epilepsy, this ill-defined head sensation, or no auras at all. So to summarize, we can say for the different lobes, these are the most common auras, and these may be the most specific auras. So if somebody were to tell you, I have a patient starts with epigastric aura, rising epigastric sensation, then blanks out, licks his lips, your guess is very good that this is likely temporal lobe epilepsy. Yes. But if it is abdominal aura, but he does something else, but he then thrashes and extends his arms and legs up in the air, then you really don't know what's going on, because it can be from many other lobes. But the more specific would be a primary, elementary auditory aura, like the ringing noise, the machinery noise in the ear, and an olfactory aura of unpleasant smells, and then the psychic auras. For frontal lobes, the most common is a cephalic aura, or no aura, and maybe the most specific is a phenomenon called forced thinking, where the subject reports on you, I'm just stuck on this thought, whatever it was I was last thinking of or looking at. For parietal lobe, it would be the most common and specific is the somatosensory aura, but more specific for the parietal lobe is the sensory march. For occipital lobe, of course, still the elementary visual aura. And for the insula, many different possible sensations, with most commonly a complex somatosensory sensation and affective change. But the most specific aura for seizures from the insula is a throat sensation. The patient describes throat constriction, gagging, as though they are being, suffocated, and or very severe pain. When a person has pain, they grab their limb and they grimace and cry. We have to think that it is a possible insular onset seizure.
How about aphasia, language problems?
Okay, these I'm going to talk in signs in the second half. Auras that may have lateralizing significance, somatosensory auras, particularly if it's localized with march, will lateralize to the opposite hemisphere. If the visual aura starts in one half field and spreads, you can reliably lateralize to the contralateral occipital lobe. And rarely, I wouldn't say rarely, but half the cases of auditory aura may hear sounds in one side, and that could also give you lateralizing information. Now, maybe there is one aura that may have ipsilateral lateralizing significance, and that is piloerection and cold chills. When the patient has goosebumps, and it can be verified, it's probably ipsilateral. We don't understand the neurophysiology why that is the case. Now, having just said that auras can be very helpful in the localization of focal epilepsies, you need to be aware that people with generalized epilepsies also report various sensations, and it's very tricky to sort out. So there are numerous reports now with a low of 6% to a high of 70% reporting various sensations. And very recently, another report saying half the patients with idiopathic generalized epilepsies report preceding sensations. So when you see a patient in the clinic, you have to go beyond just just hearing what they say about the sensation, but tie it together with what they have. And the question, the difficulty right now is reconciling what it is they are feeling, is because in my view, there are definitely some auras related to activation of specific cortical areas, and I think we believe that it's because in generalized epilepsy, not all parts of the cortex are equally activated at its onset. We think of it as a cortico-thalamo-cortical loop, and often it's quite possible that the seizures start in a particular part of the cortex first for the first few seconds before entering the thalamocortical system. The other thing is that some patients, and these studies can be criticized, some of them include a shock, like a myoclonic shock as an aura. To me, that is a sign of a seizure, really not a sensation. And you can imagine for people who have a series of absence seizures building up to a generalized tonic-clonic, that during that crescendo buildup of absences, they're not processing right. They are feeling weird, they are feeling dizzy, and they're not quite there. And I think they're reporting some of these symptoms that can be called auras. So we are moving to the second half. We're going to discuss seizure signs and semiology. As the latest International League 2010 proposal, they invite us to describe the patients with as much detail as we would like, sort of, using maybe a common language. So we have the basic types used most commonly for generalized epilepsies, but in fact, if they are involving just one part of the body or one side of one limb, you can use the same term for focal epilepsy. So a person can have a tonic seizure just affecting one arm or one leg. There are negative motor symptoms. They include negative myoclonus, hypokinetic, that means a non-moving state, and then an atonic state where tone is actually lost and the person falls. We can group them as more complex motor phenomenon, automatisms of various types, hyperkinetic movements, gelastic, the laughing seizure, and of course those seizures which primarily affect the cognitive sphere from a phasic absent state to dyscognitive, which is the possible successor to the term complex partial seizure. I'm going to illustrate some of these seizure types. You can describe, of course, the parts of the body involved, etc. Now, some of these signs I'm going to illustrate have lateralizing of significance, and that's why we would spend a little bit more time on them. The most important include head version. This is the head turning just before the patient enters into a generalized tonic-clonic seizure. Now, this is much more reliable than the early head turning, which can be, as you can see, ipsilateral or contralateral, and therefore quite misleading.
So early head turning during the ecto?
Yes.
So we're talking about pre-ectal.
These are all, no, this is ecto now. We're not talking about auras anymore. We're talking about an actual observable motor phenomenon in seizures.
Sorry, okay.
Yeah. But, all right, version. Then facial clonus, pulling of the face and twitching of the face on one side. This is an interesting sign, but I don't have a videotape to illustrate. The unilateral eye blink, which is more like a quiver around the one orbit. Both upper and lower lids would quiver. And the interesting thing is that it's ipsilateral, and we still do not know the exact basis. Some people think it's because these are usually from the temporal lobe, that somehow there is discharge affecting the seventh nerve in some way. We will illustrate the dystonic hand phenomenon, which is most commonly seen in temporal lobe epilepsy, but also in other lobes, and it's a contralateral sign. Another sign we'll illustrate is a figure of 4, which I think will be easier once you see the video than for me to describe. Then for speech, if there is actual formed responsive speech during the seizure, it's usually a sign of a non-dominant hemisphere seizure, somehow releasing the language hemisphere. But if there's speech lost aphasic, particularly during the seizure or posictally, then we are talking about dominant hemisphere seizures. Eye deviation by itself is very unreliable in the absence of version. If a person just has unilateral hand automatisms, for instance, it is usually ipsilateral to the focus. And the thinking is that it's as though the contralateral limb is paretic or not moving. So only the ipsilateral limb is moving. And for automatisms with preserved awareness, a bit like ictal speech, it is a sign of a non-dominant hemisphere seizure. Of course, there are posictal signs which are important, Todd's paresis, which are contralateral, posictal aphasia pointing to the dominant hemisphere. But one interesting sign is the posictal nose wipe, which is usually ipsilateral, although not 100% reliable. And some of these I will illustrate.
Looks like Adam.
Is that the most nose wipe?
All right, this is just restricted little twitches constantly in the left hand and arm. Nice case of epilepsia partialis continua. Consciousness is preserved, etc. This, pardon?
I was just saying. Yeah.
Guilty.
He said no, it wasn't right. I asked. I asked the same question.
And this is the easiest to localize based on the motor homunculus coming from the hand region in the motor cortex. This young man had this problem for many, many years, probably starting as a teenager, if I remember right, or a child, I can't remember. He had these scans over separated over a period of 10 years, showing progressive atrophy in the right hemisphere. Note particularly the dilatation around the perisylvian structures. Anyway, his clinical evolution, semiology, MRI is very classical of Rasmussen encephalitis or Rasmussen syndrome. And ultimately, he had a hemispherectomy. He spent maybe 2 or 3 months at the Cleveland Clinic because once he came, his seizures just would not stop. And he was in epilepsy, partials continua, multiple focal motor seizures, secondarily generalized seizures, and he had a hemispherectomy, and then he had a long course for postoperative rehab. But he's done very well from a seizure point of view.
Did he have to have a hemispherectomy?
Yes, that's still the treatment of, I wouldn't say treatment of choice, but a surgical treatment of choice for Rasmussen syndrome. That's the only thing that works. Subtotal resections just do not work. So she has an aura. She knows something is happening. She's pointing to her leg. It's in Arabic, is that right? You can hear it?
Remember the color green? You stick your tongue out. Say the word house. Fish not responding. Left leg is extended and twitching. What's this? What do you do with it? Left arm up in the air, left body shaking. Stick your tongue out. Left hand tonic. Left head version.
Okay. This is another very classic seizure. Patient has an aura starting in the left foot. Then the left foot started to stiffen and jerk, and it ascended up the left side of the body, and the head twisted to that side, and then went into a convulsion predominant on the left side. And so these we can invoke the homunculus again, starting in the foot area, etc., marching along the precentral gyrus. You can imagine what are these terms besides M1, motor 1. Maybe you may not know about this, but this is an interesting thing. This is not easy to illustrate, but PNMA means the primary negative motor area. In invasive EEG recordings, when we stimulate this area, it causes interruption, inhibition of movements, or loss of tones. If somebody is holding something in the hand, it will drop. And rarely people have seizures like that, and it will illustrate that.
Atonic seizure? Is it related to the atonic seizure or not related?
No. Well, it could be, if it's a focal atonic seizure, it could mean this area, this negative motor area is involved. But if we're talking about the atonic seizures in the developmentally disabled, induced syndrome and other, that's usually a generalized disorder, and the atonia is thought more a projection of the atrial discharge into the brainstem structures, as we know, not because of a cortical involvement. And easy, she has a lesion right in the motor foot area. Now, here we will have some of you help us point out the lateralizing signs. Let's see. This is a very long seizure, so I'm going to start here. He has an aura starting.
Did you feel anything before it happened? That funny feeling in your tongue? Okay.
Funny feeling in the tongue.
All right. I'm just watching the clock to see how long it lasts, okay? But you don't feel numb. Squeeze my fingers.
And the seizure is going on throughout.
That one's not you. That's somebody else. Can you tell when they're over? Do you feel any funny feelings stop? I need some help. Okay.
Okay. So there are two signs here that are lateralizing in significance. Tell me.
So you mean the beginning when he said that he's smelling, he's
No,
tasting
no.
something, or are you talking about?
He has a tongue sensation. I can't
Which
tell
maybe
which side it is
gustatory-
on. Yeah.
Okay.
But signs,
So
observable.
he did point his face to the other side, but that could be contralateral.
So that is what we mean by version, this forced head turning right before the generalization of the motor seizure. That's one.
And I'm not sure if you mentioned that, but I mentioned that Hakimi mentioning that that's fencing sign. I'm not sure if
Yes, this is the sign of 4. Look at this.
Yeah, it's this one exactly.
So imagine one arm is extended and the other arm crossed above it. And the extended arm is the one contralateral to the focus. So in his case, both of those signs, head version to the left and a sign of 4, so-called, with the left arm extension, points to a seizure starting from the right hemisphere. Okay, head version. There are some differences. For temporal lobe seizures, there's a longer latency to the version, maybe representing a longer spread of the seizure out of the temporal lobe. For extratemporal seizures, it's shorter. The sign of 4 is this extension of the arm contralateral to the side of seizure onset with the flexed arm ipsilateral. And it can evolve, of course, to a bilateral seizure. These signs are pretty reliable when tested with a correct predictive value in the 90 to 100% range.
So do you know why? Why is the ipsy arm bent? What causes that?
Not in the sense that we don't understand what motor program is being evoked by the ecto-ictal discharge. But another sign, we have some better idea, but the next one we're going to illustrate, this one.
Smack, lip smacking. Too much.
So there was a sign there, and the sign was this is the best time to, let's see, the hand. You notice it's very bizarrely postured, like some fingers.
The stonic.
Yeah, we call that its tonic hand, where some fingers are flexed and some are extended in sort of a, like hand dystonia. All right, so that is a dystonic hand, and it's a sign reliable for particularly in temporal lobe epilepsy, and it occurs usually before the secondary generalization. And this one, we have some idea what is the basis. The ictal discharge has to invade the basal ganglia for the sign to be to manifest. So we have to remember that in seizures, although we always think about the cortical origin of seizures, and which is true, the propagation can go through many subcortical pathways as well. So for each side, it's the contralateral dystonia, basal ganglia that's affected. This was a ectospect that tracks blood flow during seizures. And again, it's...
Do you think seizures would originate from the basal ganglia?
I would be most interested to see one. I haven't seen one yet. Don't know. We are looking for these things. So again, it's a very reliable sign, and more reliable than just stiffening of the arm, like just stiffening out, tonic posturing, or an immobile limb. Oh, I think I cut it short, so I better show that part of the seizure.
No, just with the right hand? Okay. Can you tell me what this is? What's this? Do you know what this is? What is it? Good. What do you do with it?
Post-ictal sniffing, ipsilateral localization.
Good. What color is this flashlight?
Right?
Yeah, or nose wipe. It's
Nose
tough
wipe, I mean,
to
yeah.
say. In his case, he did sniff first, but usually they just sort of wipe the nose or pluck the nose, touch the nose. And it's usually ipsilateral, but it's a...
And why is this too? Do we know?
Don't know.
Okay.
I mean, one possibility is that the contralateral hand is not used for wiping due to neglect or post-ictoparesis. That's the same idea. If one hand is engaged in active automatisms, don't think of that hand as the side that is primarily involved by the seizure, but think of the one that's not moving, that was being made paretic by the seizures.
Is that related to ictal cough in any way? Because he
That's
kind of coughed with the...
That's very common, but of course cough cannot be localizing. So I'm trying to discuss the signs which may have some lateralizing values. So not bad for medial temporal lobe epilepsy, but not very good for outside temporal lobe.
Oh,
He's in a seizure.
help me, God. No, God. Oh, God. No. Oh, God. No. Oh, God. No. Oh, God.
You okay?
Mm.
Come on.
Oh, no.
Remember the color blue. Remember the color blue. Can you point to the door in the room? Point to the door in the room. Can you say the word house?
House.
Can you tell me your name?
My name,
What is your name?
Jared.
Okay, what are you feeling right now, Jared? You can put your arm down
I'm
now.
feeling kind of dizzy, kind of.
Okay, can you tell me where you are right now?
Well, of course, firstly, if you encounter something like this, your first question is, was it a seizure or not? I can verify it was a seizure. There were ictal patterns, etc. So do you think there are any signs that help lateralize?
I think when it seems so bizarre, I think of frontal lobe, but probably that's not.
No, just the side. Which side of which hemisphere do you think it's coming from?
Non-dominant.
Non-dominant, yeah, exactly. So it was an idea to illustrate when you have complex speech and responsiveness, you're dealing with a seizure from the non-dominant hemisphere. It's as though it releases right? We don't know the exact reason, but anyway, it allows the language hemisphere to still participate. By comparison, dysphasic seizures, whether ictally or post-ictally, would of course represent seizure from the dominant hemisphere. And some people actually have lip-smacking automatisms while they are talking, and usually that's from the non-dominant temporal lobe. I'm going to...
Seizure? Seizure? What's going on? Seizure? Seizure. Seizure.
Remember the color pink. Okay? If you raise your right arm in the air, raise your right arm. Raise your right arm. Okay. Point to the window. What's your name? What's this? It's yours? What do you do with it? What is that? Yeah.
It's my shop. Why?
It's your shop?
Yeah.
Okay.
Okay, I think you got a point. He is very dysphasic. He could not name, he could not process. And so an examination of particularly the posictal phase is very helpful. Old study from Michael Privatera in Cincinnati, just using cutoff of the ability to read a paragraph shown to the patient at 60 seconds can separate the left dominant temporal lobe from the right non-dominant temporal lobe. Now, there are all sorts of very interesting things happening in epilepsy. We have people doing strange things, spitting, yawning, kissing, singing, and they all invite a lot of interest to try and understand what circuitry is involved, which part of the brain involved. And sometimes we have some ability, but I have to admit sometimes it's not so easy. So for instance, early on, spitting was thought to be, and vomiting was thought to be more right temporal lobe, but I think we see these in other situations, maybe kissing and non-dominant. So these are still works in progress. Now, the neurological basis of automatisms is extremely complicated, and I don't know for each case we can point to the specific factors. At least these are some of the things I was thinking of, that they are both ictal and post-ictal mechanisms, and some presumably related to activation of certain behavioral circuitry, let's say coordinated behaviors. Others are agitated behaviors that seem to usually invoke activation of both temporal pole and medial frontal structures and hyperkinetic behaviors. But others could be more of a release phenomenon, as I said. And it's well known that a seizure can terminate and the patient continues to exhibit things like lip smacking. So some of this is really post-ictal release. And some of the behavioral alterations in patients, particularly the restlessness and agitation, could be secondary changes in neurotransmitters. I'm going to move ahead, not illustrate this one because of the lack of time. I'm going to illustrate this seizure because it's very interesting.
Okay, baby.
Remember the color green? Remember the color green? I pushed it already. I pushed it already. So what happened? Describe what happened. Just happened.
What was that? I took one.
But do you remember anything that happened prior to that? Do you remember what color I said when I came in the room? Can you tell me your name?
Mark.
Can you point to the door?
Okay. It was a seizure, all right. He had a very small area of dysplasia in the orbitofrontal lobe and type 2 cortical dysplasia, and that was resected and he was fine.
What kind
Was
of
there a
seizure did you
localized?
call that?
Yeah.
Yeah. because the right and
Complex
he
motor.
snapped his hand also on the
Or-
on the same
yeah.
side.
And the legs both going.
And they're both going.
Yeah, yeah. This one is even more dramatic.
You're okay. You're okay. Daniel? Daniel?
Yeah.
You okay?
Yeah.
Okay.
That was another medial frontal epilepsy.
It's just
Sorry, that
looks
was medium front?
Yeah, yeah.
So like there was a lesion, right?
I can't remember exactly what the pathology was, but we localized it medial frontal. I can't remember though.
Dude, you guys just won't. Why don't you just ask her? Talk to her about
Remember the color green? Okay, well, sorry, honey. You got your vitals? No. You finished?
I don't know.
You don't know? Okay. What's your name?
So this is wonderful example of a gelastic seizure. Now, I'm going to of course show you the answer slide, but remember actually it's not specific to this pathology. It can be seen in other areas as well. This is from a hypothalamic hamartoma, the classic cause of gelastic seizures that can start from infancy. And this is a really, this one, sometimes the laughing in gelastic seizures is really not very mirthful, very forced and more like a series of grunts and exhalations. But this example, I think we all agree, is very much like pure laughter. But when you count it, if you don't see hypothalamic hamartoma, other considerations could be temporal lobe seizures, can sometimes do that. Now, we don't understand the basic neurophysiological circuitry for that either. So I'm trying to illustrate that when we want to understand a seizure, particularly for an individual, we want to understand it from its beginning, from its aura to its functional manifestations in different stages, ictally and post-ictally, and that allows us to construct an idea which how the brain and the circuitry is involved. Just like with auras, occasionally in people with generalized seizures, they can have some focal findings that can be very misleading. And in particular, the head can go to one side in some people with primary generalized epilepsies, like SA in juvenile myoclonic epilepsy. And that's where the EEG is needed as well. So we have illustrated then that there are multiple bases for seizure semiology. We have activation of primary sensory areas, spread to symptomatogenic areas, activation of behavioral circuitry of one sort or another, or it could be a result of deactivation or inhibition of functions or release of generators, and then of course post-ictal changes as well. So attention to the auras and to the semiology is extremely important. even in 1992, Glua was one of my mentors in Montreal, was already saying that in this era of high technology and investigative procedures commonly used in a diagnostic workup of patients with intractable seizures considered for surgical therapy, a careful history taking has lost none of its diagnostic power. And in a recent attempt by my colleagues at Cleveland to look at the reliability of semiological signs for localization and naturalization showed that semiological features can still be as important as the EEG, as the MRI, in helping us figuring out where the seizures are coming from. So with this, I end. Thank you. I believe I'm to escape and see if there are questions, which I don't think there are. Oh, hang on. Patient with left motor seizures appeared unable to follow command speak. How would you classify the seizure using the left ILAE scheme? Motor seizure with dyscognitive. Well, in answer to that, I think one can add both, but I think most commonly, if the dominant feature is that of the motor aspects, one would mainly just use the most prominent feature. And that's, but what Dr. Ransom alluded to is precisely some of the difficulties. If we don't include whether the person can interact and speak as an index of consciousness, how do we deal with practical things like advising the person whether they can drive or not? So I think if that's the case, then indeed it is reasonable to add both that they have a left motor seizure and dyscognitive features. Yeah.
In EPIC, do we have both the old and the new class? We have a drop-down box that has all of these things.
I have not used seizure types in EPIC. I just mainly choose the epilepsy type.
What you're saying about localizing, lateralizing, I understand, better or as good as EEG, but you're not going to get that without the video portion of the EEG.
You're right.
I mean, because most patients, or if you see the seizure, and video is invaluable, because even when I observe a seizure, like as a neurologist, and I go back and write a little note about it later, I'm always like, what happened next? I try to write it down, but you're kind of, agitated.
Yeah, without the video allowing us to go back and look at the details, it is very difficult.
Yeah, but some of those are I don't think if I've seen this, I haven't noticed it, so that will be a good thing to look for in this.
Do you think when you think about like migraine with aura, do you think aura is in that setting? I guess it's kind of impossible to know because you don't have a EEG correlate, but do you think they have similar localization values?
Migraine or auras. Well, firstly, actually, a number of people have studied people during migraines with or without aura. And I think the literature can be a bit complicated because some seizures, occipital seizures, have headache as a prominent part. So it depends how you tease it out. But in general, I think most of us believe that in true migraines with visual aura, you do not see a scalp EEG change in the usual sense. All right. I've seen one case of hemiplegic migraine that got so bad, the person actually had periodic lateralized epileptiform discharges as an aftermath, presumably reflecting the severe degree of ischemia to that side of the brain.